Good day, and welcome to Diagnosing Health, a podcast that looks at all the different problems within the healthcare system. And one of the, I think, big issues with healthcare, especially in Malaysia today, is that of cost. So, to pick a little into this subject, particularly in an area which is close to my heart, as well as an area which is of a lot of concern to a lot of Malaysians, is within the area of lung cancer. Today with me, I have two very special guests. The first is Dr. Vijay Munusamy, who's a consultant respiratory physician with University Malaya Medical Center. And joining him is Mr. Jonathan Teo, who's with Calcis. Hello, gentlemen. Welcome to the show.
Thanks for having us here.
Yeah, thank you, Dr. Murali, for the kind introduction.
Okay, and let's swing right into it. Today we're talking about lung cancer. Lung cancer is a very difficult disease to deal with in Malaysia, and maybe Dr. Vijayan would be very well placed to kind of tell us a little bit about how bad is lung cancer in Malaysia, Dr. Vijayan, and why is it such a big problem for us?
Yeah, okay. I think lung cancer is actually surging. If you look at the statistic locally and also internationally, and we can see it's number 3, the most statistically significant causing the death in Malaysia as well as in the whole world, especially in advanced lung cancer. I think the main reason that we have the issue of identifying early lung cancer is because the nature of the disease itself, whereby in early lung stage, like stage 1, stage 2, patient are asymptomatic. They don't have any symptoms, Unlikely if a breast cancer, suddenly you palpate there's a lump, then you take a proactive to look for it, whether it is a fibroadenoma or malignant features. So most of the patients, 60 to 70% patients, early lung cancer are asymptomatics. Now that is another important where many of our patients, not even in Malaysia, Southeast Asia as well in the world, that many patients presented later stage 3 or stage 4.
Right. So basically you're telling us one of the most common cancers in Malaysia today, affecting women and men, and most importantly, almost I think now 95% for all our cases are in stage 3 or stage 4. Really, then I'm zeroing in on the cost, Dr. Vijayan. How much does it then cost? What's the kind of difference when you treat lung cancer in an early stage in terms of dollars and cents, ringgit and cent, and in terms of late stages, how does the kind of diagnosis really change?
I think the most important points before we go into an economic perspective, I think go into the patient's benefit perspective.
Okay.
If you talk about early lung cancer detection, I think we are talking about a curative therapy. It means patient can cure from the lung cancer for many years. For instance, a study was done in WHO shows those who are stage 1 cancer, the curative possibility is in 90%, which is not many cancer can provide this. But if you talk about stage 4 cancer, the survival is more than 5 years, is only around 5 to 20%. So that is the survival benefit in terms of patients. But of course, if we talk about translate into the economic or in terms of the expenditure, early lung cancer actually provide a much lesser cost. Malaysian Thoracic Society in 2019 actually published a consensus telling that if we diagnose lung cancer in early stage, reduce the cost 5 to 15 times lower than later stage. So if you talk about lung cancer, let's say a person diagnosed lung cancer required lobectomy or segmentomy in the MOA setting, the cost is around 5,000 to 8,000. That's already shown in the Journal of
This is in the Ministry of Health.
Ministry of Health. If you talk about private entity, it's 25,000 to 30,000.
Okay.
But if the patient presented to later stage, for example, stage 3 or stage 4, of course, the cost is exponentially high. If we talk about the Journal Economic of in Asia, it shows the price can go up to 150,000 to 300,000 per annum. So this is a direct and indirect costs. So you include your inpatient costs, imaging costs, and also the medication costs.
Right. Thank you, doctor. So I'm going to focus away and take you to zoom into Mr. Jonathan. Mr. Jonathan, you're with Calcis, and just kind of refresh for the rest of us who are kind of watching this. What is Calcis? What do you do? Why are you in this chair today with us?
Well, Calcis is the 4th pillar in terms of funding, because traditionally we always have seen funding sources from government, from insurance and personal expenditure. So we're coming as a fourth pillar from the capital market side to put more options on the table for seniors, especially those 60 and above, where we see a lot more incidences of lung cancer, but unfortunately may not have the insurance coverage because they either left their employers, so don't have the employer health insurance, they don't have SOCSO coverage, and they may also be not able to sustain their insurance premiums because it's escalating higher and higher in line with medical inflation. So what happens then is that Kelsys comes in to offer them a solution where they can unlock the home equity of their home they've lived in without having to move. So practically, you can stay in your home and take the cash out to fund your treatments and your retirement expenses for life. So in the first year, Kelsys pays 10% of your home value at market value. So imagine a 1.5 million ringgit home can fund immediately 150,000, which matches to what Dr. Vijay had said for many cancer indications. But then subsequently, we will fund between 3.3 to 4% of the home's value for as long as the participants are alive. So which means if the husband passes away, it will keep funding the spouse until she passes on. And that's when the scheme ends. And this could be for easily 10, 20, 30 years, no one knows.
Got it, sir. So here is the problem. We're looking at most Malaysians being diagnosed in stage 3 or 4 of lung cancer when they're presenting in Malaysia. Dr. Vijayan speaks to us about how costs, they're looking at about 150 to about 300,000 per year. And sorry, Dr. Vijayan, I just want to get a clarification. This is with this kind of level of treatment, patients are doing well, they're surviving.
Yeah, I think that's depend on the type of cancer as well. Okay. If you talk about the non-small lung cancer, the adenocarcinoma, who have a targeted mutation, of course, the overall survival and the prognosis is much better.
I'm sorry to have to corner you. How many years are we talking about?
Okay, if you talk about the targeted therapies, of course, it give more than 23 months to 16 months an advantage for those patients who have not on the targeted therapy. Of course, this is what the study shows. In reality, we have seen patients on targeted therapy live more than 3 years, 4 years, even 5 years without the patient have a disease progressed.
Right. And now I'm translating directly into dollars and cents, which means there is some clinical benefit, there are drugs available, but you're looking at about 1.2 million ringgit that you need. Now, and this is where I think we start looking at or talking to people like Mr. Jonathan and looking like, how do we get to this 1.2 million? And I think it's good that Kelsys is one of those solutions that maybe we can look to unlock this kind of conundrum. But I'm just going to go back a little bit, Dr. Vijayan, before I come back to Mr. Jonathan. Sir, please share with us, you talked to us a little bit about targeted therapy. I know we often speak about immunotherapy as well in lung cancer. So what's the kind of differences and who's maybe suitable for these drugs? But also, other than these drugs, what are the other costs involved in treating lung cancer? Where do we need to spend the money?
Yeah, okay. I think that's answer straight. There's a cost, a direct cost, and it's hidden costs. So you talk about direct costs, you're talking about investment towards your medications. That's usually what most of the patients are calculated upon and we worried upon. That's what we know very well. So if you talk about targeted therapy, let's say the patients have EGFR mutation, stage 4 lung cancer, you want to start patient on the as cheapest as Gefitinib, because we know Gefitinib, we have a lot of generic. The cheapest one we have in University of Malaya only costs you 400 ringgit per month. But even say that Gefitinib alone will not give you a good prognosis. Eventually, the patient will disease progress. So most probably the patient need to change from first generation TKI, need to go to second generation TKI. So when you go to a higher end TKI, you need a much higher price. So it costs you approximately 6,000 per month. So that we're talking about EGFR patient who are disease progress. So let's talk about those patients who are require immunotherapy. Unfortunately, this patient have no targeted mutations. They see the PD-L1 is more than 50%. The study have been shows, iron power study shows patient will benefit immunotherapy like what NCSM doing for pembrolizumab. So the pembrolizumab cost per month is cost you 17,000. So you can divide it, the patient require approximately 12 doses in a year. So you can multiply, it's costing more than 120,000 to 150,000 in order patient to survive. Of course, immunotherapy have shown much better survival compared to those patients not on the immunotherapies as well. So these are the patients we're looking at it different perspective, different requirement as per patient needed. If the patient just required chemotherapy alone, just a combination of which commonly given pemetrexed and a carboplatin, most probably patient will spend around 1,000 to 2,000 ringgit. But most of the studies shows patient will not survive much longer with the immunotherapy arm, where you need to actually change to a first line, second line, third line, fourth line, fifth line, sixth line, even seventh line. So it depends on the tolerability of the patients.
Right.
And of course, each upgrade of your level of treatment increase your toxicity, increase of the price as well, and probably your patient have more of a side effects and you require hospitalization and everything. If you talk about indirect cost, there's a cost of the patient's family member who taking care of the ill patient. They might not able to do the business. For instance, the patient's son may be having sundry shop. Maybe he need to close the shop for 3-4 days. Or the patient's daughter having own business, selling online business. The father was in hospital. Maybe they need to take care of the father. If the unfortunate, some patients only have one children, one son, and emotional, psychosocial, the transport costs, all those things is not accumulated and not counted costs where we don't actually talk about in our public, So this is what I think NCSM recently come out, the idea of navigation, patient navigation program. So that is very, very helpful in terms of overall restructuring, in terms of psychological, financial, assisting the family member throughout the journey of the lung cancer patients.
Got it. And coming to this assisting patients idea in terms of finance, Mr. Jonathan, you started working in this landscape, say about 2 years ago, 3 years ago, and I'm sure you've exhaustively looked at what are the kind of different financial aid that actually patients can get. Could you maybe share with us some of the more common kind of financial assistance that's available, and why maybe also share with us why is this not enough?
Yep. So I think this is why we're different as a financier. We do think we actually handhold patients through the cancer journey. It's something that you will not see any other financial institution doing. But because we're mission driven, we're different. We're committed to this. And the first thing first is that we always look at how do we stretch the ringgit to make it count more. So one thing we do for sure is work with the patient to put them onto patient assistance programs. So like what you mentioned about pembrolizumab and all these others, there are patient assistance programs which bring down the cost significantly. That's to a point that they can fund this. And to that effect, we also design CALSIS based on today's costs of these cutting-edge medicines, so that we know that we can cover quite a wide range of all these prescriptions that are suggested by the physician, and that we could be funded.
So this is patient assistance programs.
Yes.
Are basically programs that help bring down the drug costs. How?
Yes. So, for example, you could do a buy one, get one free, that sort of thing. So, for example,
Kind of a bundling
thing.
Okay, so it makes it cheaper for
Yes.
patients.
So the overall cost, even though, let's say, one of those boxes of targeted therapy for lung cancer, it might cost 20,000 ringgit, but you might have buy one, get three free. So then the effective cost per month basis is 5,000 ringgit, which becomes a lot more palatable and can be funded, and we can get patients onto that. So that's one of the biggest lever to create awareness about this for patients, because we take it that when they get cancer, they have no knowledge, no background knowledge in healthcare on this particular field, and they don't even know where to start. So that's why we have in our team medical liaisons that handhold them and actually point out where are these areas they could tap on. And of course, this is not the only one. There are other things which they qualify. They can get zakat.
Okay. How does so zakat works? Zakat is how do people get to zakat, sir?
Well, you have to apply for it, and it differs depending on the jurisdiction you're in.
Okay.
So that's why we had to even go down to ground with our medical liaisons to look at how do we do that? How do we connect the dots so that our patients don't waste the time applying, but yet we layer on all these things, like we've got CALSIS, we've got zakat, we've got other patient assistance programs. So that way, it all combines together to fund your immediate healthcare.
For sure. And we'll get to how this entire enmeshing actually will help end up doing better for patients. But I'm coming back to the question or the track that we started on. So we looked at patient assistance programs. We looked at Zakat. What else is there out there?
Well, that's also not only with CALSIS, but also because CALSIS is one more layer, but then also you have EPF, especially with for loved ones. You could always children could always help support their parents' medical needs from their own EPF accounts.
Okay, so people can make EPF withdrawals for themselves. We're all aware of this. But first degree family
Yes, that's also
can make withdrawals for their family members.
yes.
Okay, so that's another kind of financial aid, but I don't know. EPF is basically you depleting your own savings. Okay, what else do we have on the landscape?
And unfortunately, that's what we see presently.
Okay.
And
How about government programs? I know we talked about previously, or we always seem to talk about PERCA B40. How does that work? Doctor, you work in the system. How does PERCA or My Salam, how does this?
I think the PERCA and My Salam is mainly to the B40s.
Okay.
So I think the amount is being offered is not huge. Like PERCA is 1,000, My Salam is offer you 8,000. So if you go back to the idea of let's say the patient comes with some very symptomatic stage 4 lung cancer. Let me give you the overall pictures or the causes in Ministry of Education of Education per se or Ministry MOH. So as you talk about
Sorry, doctor, just to clarify to our viewers, so there's 3 packets.
Yeah.
There's the Ministry of Health. Everybody thinks that all government is the same. It's not, yeah? So there's a Ministry of Health hospitals, different costs. Ministry of Higher Education, your university hospitals, different costs. And then, of course, there's private hospitals. So coming back to you, doctor.
I think you have talked about this loud and clear in a BFM, I think 6 months ago. There you mentioned it, there's a study done by the family medicine physician that if a patient got any symptom, go to the primary care. In order to get an appointment in primary care, going to the tertiary care, it takes 6 months. Yeah, I think you talk about very clearly. So that is the gaps, number one, beside the monetary wise. So if a patient has PERCA, they have to go to the GP. And the GP will write a letter to even the private. If you go to the private, let's say the patients have 8,000 ringgit. So most of the procedure for lung cancer, either you do endobronchoscopically or you do some advanced procedure like you do EBUS or you have to do CT guided biopsy. All those things require admission in the private hospitals. So 8,000, do you think is sufficient for B40?
Not at all. So it's basically to offset costs in government hospitals.
So come back to the government. So if you go to the tertiary hospital, for example, Minister of Education, Minister of Health, okay? So how long it will take for you to get a consultation from the respective physicians or even oncologists? It take a month. The most, let's say in the average shortest is around 1 month. Then for you to get a CT scan, it's another month or 2 weeks. Maybe you had a good system and you have a much leverage like Unistimula, 2 weeks. So you have a 6 weeks. Then to get the diagnosis of histopathology, another 2 weeks. But you have to wait for the molecular study. So you are actually, there's a long gap. So what we have done uniquely in UNIST Malaya and also Dr. Arvind in Alostar have done this strategy. So what I've done is all of us, because we treat the lung cancer every day in UNIST Malaya, we have to given the most earliest appointment because we have a clinic on Monday, Wednesday and Fridays. If ever got a referral from GP highly suspecting lung cancer or a patient already done a CT scan, we give earliest possibility or any of the available slot for them to see early as soon as possible. That's number one. Number two, we always do the intervention as soon as possible. We do the intervention procedure in UNIST Malaya twice a day, Tuesdays and Thursdays. We slot them even though how busy we are, and even if you got a 4 patient do procedure, we always slot them early. Number three, commonly the clinician have a gap with histopathologists. As you know, you've been a clinician, we don't much communicate with histopathologists. We just give a call to our kind pathologist, tell them, have a patient, early lung cancer, I need a biopsy, I need the result by 3-4 days. Many occasions, my pathologists actually accommodate these strategies. So we talk about my center, we diagnose early lung cancer within 2 weeks. Then I proceed to the cardiothoracic. Prosiva is there. So do operation within 2 weeks. So we actually shorten the period of diagnosing, intervention, and intent cure strategies like a lobectomy within a month. So this is what we do. Of course, it takes a team to do that. An individual cannot do. So this is what we've done, and Dr. Arvind in Alasta also doing this, where you can see is the waiting period for bronchoscopy much shorter than the private hospital in the northern side. So these are the things you need to come from the institution itself. And I think MOH is doing much effort in order to actually reduce this waiting period. Of course, it's take time because it consists of many policies makers. I think the institution itself should make some major changes in terms of giving the benefit for the lung cancer patient.
Absolutely. And then let's zero back into this bottom line. How much does it cost to get it looked at in University Malaya?
Okay. So University Malaya is a quite unique institution, I would say. So we cater mostly all the government servants. Okay, if we talk about government servants, in terms of instruments, it will cost you less than thousands. Okay. All right. So of course, they don't have admission fees. They don't have histopathological. Then we have always ongoing study, whereby many of our patients who are new NGS strategy, we instead of 5,000 in private, we get 1,000. All right. And
if
many of our
get on to a clinical study.
And of course, we have an in-house which is offer much cheaper NGS as well. Then many of our patients, we try to enroll them into our clinical trials. So we have more than 20 clinical trials, respiratory alone, with our oncologists as well. So we will always encourage our patient to enroll into the clinical trial so that, as you mentioned again, these are B40 patients, we can benefit cost-free treatments, and of course, they can get the upstream treatment for their benefit of the patients as well.
Right. And maybe from the both of you all, because you come from very diverse backgrounds, but here you are sitting together. How is it that you're building partnerships, and how can these partnerships build better outcomes for patients as a whole? Maybe we can start with Dr. Vijayan and then we can come to...
I think as Jonathan have mentioned earlier, I think Kalsis give another perspective. Some patients who are actually need or who cannot go into the clinical trials and required a specified treatments, so they actually can look at that options. Even though we are already exhausting our zakat for all the diseases, we also refer zakat not only for the lung cancer, we also refer zakat for even the severe asthma patient for biologic drug. We also refer the zakat for even for the obstructive sleep apnea to obtain the CPAP machines. So I think in term overall, zakat also extremely exhausted, and they also have a limited fund in term of financing for long terms.
And this you're only talking about lung. We haven't even gone into all the 1 million other diseases that Malaysians suffer from.
Yes. So I think Kalsis actually offer another platform for patient to explore. Of course, the decision comes from the patient itself to explore in terms of whether they go for this option or they not go for these options. So always giving many options to the patient, at least help them in terms of them to guide them, and also they can actually choose a best treatment for their survival.
Yes, but for our end, we look at it from systems perspective, because Dr. Vijayan would look at from clinical perspectives, and NCSM would look at their levers being community. So we all bring a unique lever, but when combined together, creates a very, very good outcome. So for us, it's all about systems. Where can we fund? What can we do to help stretch resources? And one of the things we see is that there will not be enough cancer centers to meet the needs of our aging population with the number of cases we're seeing coming by the volumes itself. So we recognize that there has to be a shift towards secondary prevention, and where people can get diagnosed earlier, like what Dr. Vijay says, and where your economic costs, not counting only the physical costs, it's in under the tens of thousands, that sort of perspective. So how are we going to get that? And one of them is to make is increased healthcare literacy, so like in podcasts such as these, but also to help bring down the costs of the diagnostic tests so that it's within reach. And one thing we recognize is AI chest X-rays, plus also low dose CT scans. And presently we see, at least in private healthcare, the cost averagely being about 600 ringgit, and something that not many people might be able to afford as an add-on. And so what we've done is that for this podcast and for a campaign that runs from today through to end November, we are collaborating with Beacon Hospital to bring in a special package for low-dose CT scans that's a lot more affordable, and I think matching almost like NCSM's costs over here at Nuclear Medicine Department. So the idea is that we make it a lot more accessible to people to get diagnosed, but also understand what are the costs involved if you don't do it, because you rather spend a few hundred ringgit screening regularly than to have to pay thousands of ringgit, if you are unlucky to get lung cancer and have it treated, and notwithstanding the indirect cost which you highlighted, and also the pain of going through lung cancer.
Yeah, absolutely. I think early investment in prevention, I think is a no-brainer, but unfortunately something that still remains to get a lot of traction. I think that's quite a challenge with that.
So, just add on to Jonathan said, Japan actually achieved this by doing a low-dose CT scan. They reduced 32% of late-stage lung cancer. UK reduced 20%. So I think in the Malaysian perspective, I think even for the early lung cancer awareness program should be increased significantly, so that the number of cases we diagnose late cancer eventually reduced. Of course, we cannot expect to zero. Of course, substantially, we look about in Malaysian data, 70% are actually late stage lung cancer. There's only an MOH spend around 65 to 70% of their finance for oncology drug, and only 10% they spend for early lung cancer. So I think now it must be a reversible strategy in order to actually, of course, the government eventually will save costs if it's many cases being detected in an early stage, and eventually it will benefit the patients as well. I think your program, quit smoking, anti-vaping, should be developed. I will actually always strong supporter anti-vaping and anti-smoking for our populations.
Absolutely, and of course it's much more cost effective as well. When you don't smoke or vape, there's a huge saving to your pocket as well. But lifestyle choices are sometimes quite a challenge. I think in all of non-communicable disease, lung cancer not being that exception.
But the other thing is that we're also seeing incidences of never smokers, which especially for women, that it hits them like, what, I've never smoked, I've never vaped, but why did I get that? So I then say then the only way to, even though you don't see yourself as risk, is to screen so that you can catch it earlier, because all these
absolutely. And I think it's a mix of all these factors. So risk prevention involves, of course, non-risky behavior, but also I think screening is a kind of key element to that. But let's get back a little into the tract of financing. So what we're looking at, and I want to kind of break this down a little bit further before we kind of close up the session. So essentially, we've talked about today, ladies and gentlemen, about how expensive it is to finance something like lung cancer. And even within the public sector, even within academic institutions, the pocket of the Ministry of Higher Education or the Ministry of Health, you're finding that the more expensive therapies are a little beyond what the average patient is able to pay for out of pocket. And one of those solutions today that's come to us is from Kelsys. And how can Kelsys kind of structure this? How was Kelsys actually able to formulate such a solution? And can we now use it only for lung cancer? Can we use it for all these other cancers?
Yes. So I think Kelsys is very unique because it's a global first. The Union for International Cancer Control sees Kelsys as a global first in harnessing home equity release and capital markets to control cancer. And what I always share with people that capital markets is actually a very powerful tool if wielded for good. Because imagine today in 2024, capital markets was worth 4.2 trillion ringgit. So imagine 0.1% is 4.2 billion that can be wielded, to create good outcomes. And so what we are doing is channeling that from institutional investors participating behind Kelsys to effect these such outcomes for systemic good. And I think one of the things that why Kelsys started in the first place is because the fact that we are actually a purpose-driven organization, that my family we've started up social enterprises in Malaysia before it became vogue. And, this was in 2006, before lexicons of corporate social responsibility and sustainability were, the trend. We started that in 2006. And today it's one of Malaysia's largest social enterprises. NCSM has been a beneficiary of that also in the past through our work. And what we want to do is then look at how can we now harness today's markets, capital markets, to even better close the cancer care gap at scale. Because we realize that government can only do so much, but it has very good intentions. It's got policies written in place. There's always insurance, but only for a limited number of people that can afford premiums, and those can self-pay. So how do we put together something that is a solution on the table that could help everyone, that wouldn't leave anyone behind, but would help them live better, healthier lives than the previous generations that came before them?
Absolutely. And now I think with the medical advances, we are able to see people live longer, live better with things like lung cancer. Now we have to work to see what we can do to be able to make people get to these solutions. Absolutely. So I'm going to wrap this up in the interest of, I think we're right at the end of this episode of Diagnosing Health. And I'm going to just take 1 minute to ask you, gentlemen, what is your take home in terms of health financing for a severe disease like lung cancer today? Your take home, say, maybe to people who have families. What do you think they should be thinking about?
I would say that one, don't delay, because that's what Dr. Vijay had alluded to. We're talking of it's trying to squeeze out weeks to intervene earlier to achieve a better clinical outcome. It's the same thing for a decision of financing a particular track that you've decided on. Don't delay, because that could lead to not so good outcomes in the future. But the thing is that for the families that are thinking, do I want to do this? You also have to think of the other costs that what Dr. Vijay had said, that you would then pass this cost to the next generation, that the children have to fund their parents' healthcare, that they have to close shop.
But parents funded their healthcare, the children's healthcare.
Wait, I'll come to that. But it's just that
So it's time to give back.
it's time to give back, because rather than to expect an inheritance, let the parents, they've done so much for you. Let them use their wealth to take care of themselves and not burden you. That's the one key takeaway that I'd like to share with people, because the cost of that we're seeing is that with some patients we're seeing that some sisters, for the mum, they are telling us they can't afford chemotherapy anymore in private healthcare because the mum has expended all the EPF, has used up all the credit card limits and everything. They have nothing more to give. But you look at it, they had to delay starting a family. They had to delay all the aspirations and their dreams of living better than parents, because they had to. This was the burden, and that's why we did CALSIS, because we can help lift the burden, walk with them through the cancer journey as a trusted friend, sharing with them the best insights on how to maximize the resources you have in hand to live a brighter life ahead.
Right, doctor. And you are one of I think the people who struggle with every day trying to fight the battle of getting the correct solutions or treatments to the patient, but also balancing the kind of costs. How could we do better for you? How can we arm you better? What can we as Malaysians do to help you guys treat your patients better?
I think the most important as a clinician, even all of my clinicians agree that prevention is better than cure. It's number one. So I think even in all the media, in all the newspaper, we can see if you're more than 40 years, please do your annual checkup. So I think that's a very fundamental education should be actually disseminated in all the schools, even in the corporates or even in the NGO, as like NCSM should actually propagate this awareness, So I think I will share with you a case that NCSM having a mobile clinic recently. So the patients who are detected, the CA was mildly elevated and was admitted, then we diagnosed early lung cancer. So such initiative actually will change a patient's life. That's why I say prevention is better than cure, and early diagnosis is the key to success. We can't actually put much hope or invest more on the late stage because we know the prognosis is poor. But whatever will be done is our take-home message, even our lung cancer network initiative is actually early diagnosing and prevention is the key to reduce the number of the lung cancers in Malaysia.
Absolutely. So thank you both, ladies and gentlemen. Ladies and gentlemen, today we talked about this is our diagnosis in health, how to get better financing solutions to pay for the extremely good solutions that we have to make sure that our people live better, longer lives. This is Diagnosing Health.